All right. Thanks everyone for joining the meeting today. We're gonna start with some introductions of some of the new docs that we have within our organization. I see Dr. Um, Besanov, Dr. Jupin. I'm not sure who's logged in with iPhone 52.
Oh, sorry, that's me, Dr. Jafari. I'm trying to change my
Oh,
name.
hi.
Sorry.
No problem. All right. So, all right, Dr. Besinov or Dr. Chupin, whoever wants to go first. Just a small introduction about where you've studied and some of the goals that you have, and um, yeah, just your journey as a dentist.
I probably won't be introducing myself as Dr.
Hey, Danny.
Besanov. Uh,
Oh, that's you. Gotcha.
yeah. Nice to
But
see everyone. I'm Danny from Avora. I'm going to be talking to you guys about a new platform that we're launching here, but I'll save my introduction for later in the meeting.
Amazing. All right. Thanks, Danny. All right. Dr. Jupin, if you're there, you want to take a few minutes to introduce yourself?
Hello, everyone. I'm Dr. Jupin. I'm super excited to be a part of the Clove team. I'm looking forward to it. I graduated recently from USC in May 2025, and I worked at PDS for a little bit, and I work at a different private practice now. And I'm looking forward to working part-time with Clove. I really like the family and team mentorship going on, and I'm really looking forward to it.
Thank you. Welcome to Clove.
Thank you so much.
All right. Did I forget anyone?
That's good.
I think we're good.
Yeah.
All right. Sounds good. So we're gonna start with recap, I believe. So we'll start with recap of what was discussed in August meeting. I'll do a brief overview of some of the things that we discussed, and then we have a presentation from Dr. Kwan. He's our endodontist. We are also having little get together meetings with back office team and front office as well. So I'll share some points as well. So clinical osteosurgery, the goal is to minimize the pockets between the teeth. We discussed that it's covered with Medi-Cal. So we were scheduling some consultation with the periodontist and with PPO as well. It's covered procedures, and there are low copays. So we're trying to make sure all SRPs are scheduled for 6 weeks reval. And if there are deep pockets, then we can schedule it with our periodontist, Dr. Bakian, and we also have Dr. Mara still.
So just to give you guys a little bit of insight into that, Dr. Baki and Dr. Mera in the last month have done at least 30 osseous surgeries, and the patients were extremely, appreciative of it, and they actually enjoyed the experience. So we'll be obviously tracking the pocket depths over the next few months, and I'm sure there's going to be a benefit to doing the treatment. So patient satisfaction, very good. They like our doctors and they like seeing specialists. So it's good for us as GPs to have in our back pocket that, hey, I did this SRP, or hey, my hygienist did this SRP. Why in the world are my pocket depths still 7 millimeters or 6 millimeters? So it's good to refer to these doctors just to A, take care of them. That's the most important thing. But B, also do things that maybe as a GP we're not comfortable doing.
Yes, thank you, Dr. Puri. Bone grafts, we discussed it's an important factor when we're doing extractions. We have lots of approvals from patients who are willing to pay for the bone graft. And if not, I've seen doctors do kind of, to help patients out 2-for-1. If they're doing 2 extractions, they're only charging for 1 bone grafts, or at a minimum, introducing socket plugs. So, we talked about that. It's always important to do bone grafts or at least a socket membrane um, collagen plug with extractions. Uh, yeah, Dr. O.
Sorry,
Wait.
accidentally turned on.
Okay, no problem. SRPs, Medi-Cal covers SRPs once every 24 months, and perio maintenance is every 4 months, up to 24 months. So this goes to the hygienist and also doctors. If you're seeing SRPs, you might want to confirm with front office when was the SRP was last diagnosed. If it's more than 24 months, then if the patient needs it, let's go ahead and diagnose it again. Medi-Cal will require pre-approval, so we'll send pre-approvals out and stuff like that. But Medi-Cal covers SRPs once every 24 months.
They're covering it pretty liberally too. So it's great for the patient. The fact that I know a lot of SRPs look like, okay, I can do it in an hour and it'll be coded as a prophy. That's fine. I understand that logic. But the benefit to the patient is that they get 3 perio maintenances a year instead of 1 prophy a year. So they get to see us 3 times in the next calendar year rather than once, which is a huge pain point for Medi-Cal patients. Why do I only get 1 cleaning? So it's massive for them.
Yes, for sure. Partials, cast metal only if there is an opposing full denture for Medi-Cal, and resin only if it's greater than 4 teeth in the posterior and 1 anterior missing. Dr. Puri, did I read that right?
That's correct. Yep. You need that great 4 or more posteriors missing in addition to an anterior tooth missing.
Right.
It's pretty stringent on what is covered. Cast metal is easy to figure out. There's an opposing full denture, go ahead. It will be covered.
Yeah.
We rarely see that though. That being said, I think it's important for us to realize that the cast metal dentures are significantly better, right? So just because Denti-Cal is covering a resin, and I do want to make the differentiation between a resin and a Valplast. This is not a Valplast. This is an acrylic denture. So Valplast is a much more expensive material. So we're not doing Valplast. It's much more flexible. So a resin base is an acrylic denture, partial. So if they drop it, it will probably break. A Valplast usually doesn't break on the first drop, and a metal will basically never break. So I think as we have to remember that, okay, a resin may be covered, but a metal is way better. And if the patient has other teeth that are guarded or poor prognosis, the lab finds it significantly easier and better long-term prognosis for the whole denture to add a tooth to a metal than to an acrylic. Sometimes when you add a tooth to an acrylic, it breaks. And then guess who's on the hook? We are. Patient will blame us. So something to consider. And a lot of patients understand that this metal is better, it's stronger, it looks better. So even if a resin is approved, we should talk to them about metal.
When we're sending this in to IcoDent, should we be specifying if it's a resin base?
Yeah.
Yeah, should. Everybody should be specifying resin base partial.
Yeah. So when we're sending our lab instructions, just like when we're doing anterior crowns, we say layered zirconia or PFZ versus zirconia. It's the same idea. So there's resin, Valplast, and then there's metal.
Yeah. So, Dr. Puri, just to expedite the insurance part of this, should we do a justification form if um, we think the partials or dentures would be covered right away?
Explain that to me one more time. So if we think something's going to be covered, we should do a justification form.
Justification form. Okay.
But if we know it's not going to be covered, then there's
Then
no
there is
point
no point doing it. Yeah.
wasting time.
Right. Okay. So sealants are covered until the age of 21 for Medi-Cal patients. And if you're seeing, a kid with the age of less than 21, let's go ahead and do the sealants for those patients right away in the same appointment. Compliance standards, we need to make sure we do documentations of each patient same day. And also, if it needs narrative, it's important to do it on the same day so we can send all the pre-auths and claims and whatnot to the insurance company, and there is no delays in processing. IOPs are required for the crowns, onlays, and SRPs. So make sure the assistants are taking all the IOPs. It helps with pre-authorization and claim approvals. So consents, I think most doctors are on top of it. They're asking the front office if the consents are signed. So something to just keep in mind if you're doing procedures, treatments, extractions, bone grafts, crowns. And also, if you're delivering a crown, if you think patient's going to come back and complain, let's get that delivery consent signed for the crowns as well. We have that in Flex. So just ask front office to get that signed if you're delivering the crowns or implant crowns. We talked about bone graft, or at least the collagen when you do extractions. Invisalign, prescriptions are important to submit it on the same day, so that way, we don't forget it and, gets processed and trays are delivered in a timely manner. Clean checks, I usually remind the doc, so if you could please check it once it's approved.
Just a quick comment about IOPs.
Yeah.
Some offices are doing it, some are not. I'll talk about it more in depth later, but these IOPs should be used more frequently. They're completely free to us. They're good for tracking as well. So if, I had a patient come in on Tuesday for yesterday with some fungus in her mouth, and she just didn't believe that it was fungus. She thought it was cancer, but it was wipeable. It was totally fine. So I took the IOPs. I got her back. I'm gonna get her back in 3 weeks for a post-op, and I'm gonna show her the difference.
Yeah.
So it's good for the patient kind of ease of mind as well.
Yeah, patient education for sure. Even the front crowns, if you're doing front crowns, take those pictures, before and after pictures as well to show it to the patients.
Yeah, with the before and after photos, take it on the iPad, take it on your cell phone. It's good for you guys to have a good portfolio too.
Yeah.
Dr. J recently got a nice setup and he's been playing around with it. So his photos are gonna look professional. I know some other docs in the group have it as well, but I was seeing photos of anterior crowns with the intraoral camera. It looks better if it's on a phone.
Yeah.
Obviously the DSLRs are better, but you can take your phone out and take some photos.
Um,
And if you have any good case studies, we'd love to share them on the website with the patient consent and also on our Instagram, just to kind of showcase the types of procedures we can do.
Yeah.
yeah. So I'd like to mention, since we are at compliance and standards, for the front office, what we're doing right now is we're writing appointment notes on almost all of the Medi-Cal patients if they're scheduled for crowns, we're writing in appointment notes whatever is declined from Medi-Cal. For example, if the patient is scheduled for 12 crown and Medi-Cal did not approve other crowns that were diagnosed, we're writing it on the appointment note. So I would recommend to review all patients' chart before you start your day. Look at what patient is scheduled for, look at the tooth chart, look at what was diagnosed, discuss it with the patient, discuss it with the assistants, create a game plan before you enter that operating room and start doing it. So, if something,
100%. Yeah. I notice, say a patient's coming in for a crown on 19 and they have, fillings on 20, 21. Just because it's not on the appointment book doesn't mean you shouldn't do it. Like it's
yeah,
just a slam dunk reason to do it. This is the same injection too. So there's no reason not to do quadrant dentistry. And if the patient had 2 crowns accepted and 1 denied by Denti-Cal, or frequency from a PPO or whatever it is, it doesn't mean you shouldn't talk to the patient about it. They still need it. You're the one who diagnosed it, a month ago. It's only going to get worse. So a lot of patients are paying for it out of pocket. They understand the value of doing the work. So we can't make those judgments of what they will and won't pay. You have to do what's going to be best clinically for them.
yeah, 100%. We've had a lot of acceptance with declined Denti-Cal crowns, so definitely. Pre-prep scans. Dr. Puri, did you want to elaborate on pre-prep scans?
I
Or
think
more
that's okay. Yeah, basically is what Dr. Josh was talking about
gotcha.
last meeting, that if you're running behind, you can have your assistant scan the arches before, just to help with the flow so patients aren't waiting.
All right. Yeah, and then lab notes and scans, make sure to review once the assistant does the scans. Make sure the notes are there, the shade is there, and then send it out
And
right away.
speaking of shade, Shrujal, I think the doctor needs to check their own shade. You can have the assistant give you a couple options, but I've noticed that the assistants tend to choose lighter shades for some reason. Maybe it's the lighting that they have the LED on top or whatever it is, but I got a note from our lab that we're getting more remakes due to shade mismatches. So I I think it's due to that we're just trusting the assistant's going to do it. So make sure you guys are checking that. That's an important step, and honestly, that's what
Yeah,
the patient remembers. That's what they
yeah,
see.
the color. Yeah. Yeah, so review the scans and the shades. Make sure the patient is satisfied, the color correct shade is selected. Reduction coping if under prepped. We talked about that as well, really quick. And regarding hemodent as well.
Okay.
Then we go into sedation logs. If you're using Halcyon, make sure we are logging it into the black binder. I believe we used Halcyon today at Marion. I hope it was logged into the black binder. So it's important to log this, sedation medications that we use, because eventually when we run out, we have to submit these logs to the pharmacy and they ask for it. I've got emails asking for the logs.
And the DEA as well, by the way. It's linked directly to our licenses. So if you're the treating doctor and you're not logging it, it's a mark on your DEA. So
Yeah.
you should definitely do it.
PAs are required before the crown preps and after as well when we deliver the crowns. Bite wings must show the premolars. Yeah, and then we have Dr. Pizza in River Park office. She's an orthodontist. She's doing an amazing job. I'm so happy that we have her on board. We've got lots of acceptance. Last week we got about 3 to 4 acceptance. out of all the consults that we saw. And then we also have Dr. Varia in Santa Monica once a month. I believe she's there end of October. I forget what date, but we'll send it in the email right after. But she's
Yep.
there in the month of October. And then we're moving a scanner to Santa Monica, so it's easier to take the scans and start treatments right away.
Perfect.
All right, we're moving into our next presentation with Dr. Kwan, if you're ready.
Yes. Hi everyone. Can you
Hello.
let me share my screen?
You should have access.
Okay.
Yep.
Okay. Can you guys see my screen? Oh, I can't go full screen. Okay.
We can see.
Yeah. So then today was just kind of I like that we have a group practice with Clove. I get to meet a lot of doctors and work with a lot of doctors. And so it's nice to talk to the different doctors that come in, and a lot of times they have questions. So I kind of want to make it today more of like an open discussion. So if you have questions, please feel free to pause me and just ask. Because I'm sure there's like burning endo questions that a lot of doctors have. So please feel free to ask. So today I just wanted to talk about things I hear from patients. I wanted to talk about some of the cases that have been referred to me, so trauma, case reviews. So yeah, we'll talk about these things today. So probably the most common things that I hear from the patients, like, oh, I had no pain until the doctor touched the tooth. Was the treatment done incorrectly? With those kind of things, I always tell the patient, like, hey, did you have a cavity on the tooth? Did the tooth need to be fixed? Then yeah, I mean, the status of the tooth changed once we try to fix the tooth, but unfortunately, you're having more symptoms that are associated with the caries that you had before, and this is what it's going to take to fix the tooth. And then when I get referred for retreats, they always ask, was this done incorrectly? And so I always tell them like, hey, this is the best the doctor could do. Everyone's just trying to help you, right? So just we're trying to do everything we can to save the tooth. And so I try to change the narrative basically. For these kind of things, like I'll never, like you can refer the patients to me. I will never, I will always back up the doctors. I will never throw you guys under the bus because nobody's perfect, things happen. But most of the time, the best thing to happen to the tooth is to not have a cavity at all. And unfortunately, that's not how it goes. And so this root canal teeth cause cancer. I mean, I get asked this all the time, or they tell me this all the time. And I tell them, like, what's the alternative then? I mean, you want to extract every tooth that needs a root canal? I mean, you have a bunch of root canals already. Do you want to extract those teeth too? And then I say, like, look, there's like decades. At this point, there's probably like 100 years of experience saying that, or research saying that root canals don't cause cancer. So uh, I I hear that pretty frequently. What about like, hey, root canal teeth are weaker? To that I say, I mean, there's no evidence that really backs that up. Here, so there's a study by Sedgley that says, are root canal teeth more brittle? So in his study, it says the similarity between biomechanical properties of endodontically treated teeth and their contralateral vital pairs indicates that teeth do not become more brittle following endodontic treatment. Other factors may be more critical to failure of endodontically treated teeth. And then here by Ray, he says, do RCT teeth weaken? So it's a reduction in tooth stiffness as a result of endodontic and restorative procedures. So here he says a root canal actually only weakens the cuspal thickness by stiffness by 5%. An occlusal cavity prep is 20% weakness, and MOD prep is 63%. So I mean, I really don't think doing a root canal on a tooth is really going to cause the tooth to weaken because 5% is like almost nothing. So again, these are things that I get asked all the time by patients. So this is a case that was referred to me. It was a trauma tooth number 8. So this is actually the X-ray that you see here, this PA, is of tooth number 8. So the tooth was splinted by Dr. O. Actually, she did a great job splinting the tooth. And her notes were amazing. Like, she had the whole timeline of events written down. I almost didn't even have to ask mom anything because the notes were so well written. But of course, I'm still going to go in and talk to mom and get the full details. So I talked to mom and try to get a timeline of the events for this case. So the patient was a 12-year-old female. She said on Saturday, the patient fell off a scooter and she avulsed number 8. Mom placed the tooth in a container of water and they went to the emergency room. She said they waited for over an hour before being seen. Mom said it was a horrible, traumatic experience for the patient. She basically said that the medical doctor that was there, they just jammed that needle into the patient's mouth, squeezed as hard as they could to numb the patient, and then put the tooth back, replanted the tooth. So when the patient came to us, I mean, she was so scared, understandably so. So that's what she told me. So going in, like based on Dr. O's notes and then what mom was telling me, I already knew the prognosis of the tooth is really poor. And so on Monday, she was seen by Dr. O. The teeth were splinted, and they referred the patient to me. So here on the following Tuesday, 8 days later, I did the consult. So, it was section number, sorry, tooth number 8, pulp necrosis, symptomatic apical periodontitis. All the adjacent teeth were testing normally. So at that visit, I talked to mom about the prognosis and long-term prognosis and things to kind of look out for. And we decided to initiate the root canal treatment. So I started the root canal, I placed calcium hydroxide for 2 weeks, and then I finished at the 2-week mark. And so here, when you actually look at the radiograph, you can actually see the incisal edge of 8 and 9. They're not in the correct plane. They're not level, right? Number 8 is extruded. So here at the apex, you can see there's a radiolucency. So usually what happens when a tooth is avulsed is a blood clot forms at this site here. And if it's not cleaned out, that clot is going to prevent the tooth from being replanted completely. So emergency, I mean, medical, they don't know anything about dental. And likewise, dental, we don't know anything about medical. So I wouldn't expect them to know what to do in a case like this. So here, this is actually, they call it Save-A-Tooth. It's Hank's Balance Salt Solution. This actually will help preserve the tooth for, here they say up to 24 hours. But I mean, nobody's going to have this. What parent is going to have something like this at home for their kid in case they knock out a tooth? And then these are the different types of storage mediums that you can use. So Hank's Balance Salt Solution is going to be the best. The next best thing is going to be milk, saline, and then water. And they actually said if they put the saran wrap, if they saran wrap the tooth, it's actually equivalent to putting the tooth in milk. So water is going to be like the worst type of storage medium because it's hypotonic and it'll cause cell lysis. The big thing for avulsed teeth is maintaining the PDL cells on the root surface. So any manipulation of the root surface is going to cause those PDL cells to die. And then the prognosis of the tooth just tanks. So this app is called it's Tooth SOS. It's on iPhone and Android. I strongly encourage all the doctors to download this app, especially if you have young children. I mean, a lot of times when it comes to trauma, you don't really know what to do. So this app really breaks it down, makes it super easy. It tells you what you should do, recalls, everything like that you could have questions about trauma. This is going to tell you what to do. So here they have guidelines for fractures, luxations, avulsions, et cetera, et cetera. And here again, because I from the notes from Dr. O and then talking to the mom, we know that the tooth was out of the mouth for over an hour. And so already with that, and the fact that the tooth was stored in water, I knew that all the cells on the root surface were dead. So here, it's a closed apex, so the patient may or may not have symptoms, swelling or sinus tract, excess mobility or no mobility, which would be ankylosis, with high-pitched metallic percussion sound. And then, yeah, I mean, ankylosis related replacement resorption is what I expected. And that's what I discussed with mom. I told her and her husband actually when they came, we're just trying to buy the tooth time. I mean, I can't imagine being 12 years old, going middle school and then going into high school without a front tooth and trying to use a flipper. That's just, I'm sure that would be really tough. So here's the visit with the calcium hydroxide. I medicated for 2 weeks. So the purpose of that was to just try to slow down the resorption because I had told mom 100% it's going to happen. So here's the final, and then here is the 3-month recall. So here, it's a little tough to tell, but the lamina dura is already starting to disappear. And when I did my test, the tooth sounded metallic when I did percussion. So again, I told mom, I reiterated, it's just a matter of time before we have to intervene again. So hopefully, the next step would be we would do something called decoronation. Basically, it's just trying to preserve the alveolar ridge so that she can do an implant in the future. I just remove the clinical crown, splint it to the rest of the teeth, and then the root actually stays there without the root canal filling material. And then slowly over time, the resorption will eat away at the tooth. The tooth will be completely, the root surface will be completely gone, or the root will be completely gone, but the alveolar ridge will be intact. So hopefully she'll get to keep the tooth till at least, or that will be good until she's 18 and she can do like an implant at that time. So, when it comes to trauma, we don't see very many cases, but early intervention is key. Following those published guidelines on the tooth SOS, it's makes it easy to follow. And then if you still feel uncomfortable treating them, refer if needed. But again, early intervention is there's going to be a greater chance of success. Any questions? Oh, and then for splinting, I actually just use fishing wire. So if you go, if we look back at this slide here, they say to stabilize the tooth for 2 weeks using a passive and flexible wire, or you can use nylon fishing line, 0.13 to 0.25 millimeters in diameter for a flexible splint. So I mean, this is exactly what I bought. 250 yards, probably last the lifetime of my career in terms of trauma. But yeah, I mean, this is all you really need. This and just some flowable composite, and you can splint those teeth. When you splint the teeth, though, you definitely want to make sure you're splinting at least 1 or 2 teeth adjacent to the tooth that was traumatized. Any questions?
Ortho wire would be okay, because I know we definitely.
Yeah. So yeah, on this slide it says here, flexible, passive and flexible wire with a diameter of up to 0.4 millimeters
Sure.
should be okay. We have Dr. Pizza is here, I think, right? She can tell us what diameter wires she uses for her cases. Or not. Okay. So then some of the GPs that I work with at Clove, they tell me that they like doing endo, and sometimes they'll run into trouble, and so they ask me questions like, "Hey, what should I do?" I really don't mind GPs doing endo. I think I did a lot of endo as a GP, and I had like burning questions too, and in terms of like case selection. So this form is from the AE. It's the case difficulty assessment form. And this really breaks down what you should look for in terms of cases that you could maybe consider tackling. And so they talk about like diagnosis, radiograph, morphology, et cetera, et cetera. But the canal morphology is going to be like the most difficult part. So here you see like C-shaped morphology is going to be considered high difficulty, extreme curvature, mandibular premolar, or anterior with 2 roots, maxillary premolar with 3 roots, so on and so on. So if you want to do endo, you should really consider the difficulty of the case before you decide to touch the tooth. And again, they talk about like medical history, if they have difficulty getting numb, limited opening, things like that is some of the things you want to consider. Like I had a patient last week where she just wasn't able to open. She had some sort of a like TMJ surgery, and where she was only able to open like 2 millimeters for a long time, and then she was finally seeing a TMJ specialist, and then she was able to open like 6 millimeters or something like that. And I had to do a root canal at number 15. I mean, that was near impossible. So things like that you want to kind of look out for before you decide to do the case. Um, Trauma history, endodontic treatment history. If it was previously accessed, um, and whoever did it before, they couldn't do it, then you know it's going to be tough. Perioendo lesions, things like that. So case selection is key. So this is a study that was done by Bertucci. He tried to classify the different types of root configurations that he saw. So there's a lot of variation in the canal configuration. And so if you look at the canal anatomy, you're going to see there's so many studies that look at the anatomy, and probably the most predictable teeth to do root canals on is going to be 6 through 11. Most of the time, those teeth have one canal. So those are the laterals sometimes can have dens invaginatus, so that you should kind of look out for too. But that's going to look really funky on the X-ray. Should be easy to spot. But again, 6 through 11 are going to be the most predictable cases. Maxillary molars. This is the one I like to quote Stropko. So maxillary first molar 93% of the time have MB2. Maxillary second molar 60% of the time have MB2. But the mandibular teeth have a lot more variation. So for the mandibular incisors, 40% of the time they have two canals. So if you see like the canal disappear on the X-ray on the PA, you should be highly suspicious that there's another canal. So maybe that's one you don't want to do. Mandibular first premolar, 24% of the time has two canals. So again, if you see a break in the canal on the X-ray, probably shouldn't do it. And then you have these other teeth here with the variations too. But I think I see a lot of GPs trying to do mandibular incisors and mandibular first premolars. Just be careful. I'd say just be careful. So these are just some of the cases that have been referred to me that I've seen over the years. So here, this tooth number 5, there's caries to the pulp. So the doctor did like an open and med, temporized the tooth, sent it to me. Already you can tell the root configuration looks really strange. So here, this is the root is dilacerated, right? It's a dilaceration. So this is what it looked like when I finished. Here's a tooth number 6, canine. CBCT working length estimate was 34 millimeters. I mean, this has got to be like one of the longest teeth I've ever seen. So something like this, if you see something like that, even for me, the case like this would be a struggle. This is a pano taken of one of the hygienists at one of the offices I go to. I mean, 6 and 11, the apices look like they're in the patient's brain. I mean, that's got to be the longest tooth I've ever seen. So yeah, I mean, if you see something like that, don't attempt, because it's going to be tough for me too.
Doc, quick question about
Yeah.
tough cases. So on the number 5 that you showed with the dilaceration,
Mhm.
what the GP or the referring doctor did was correct, right? In terms of getting the patient out of pain, opening and medding. What is the right way to open and med a tooth like this? Because clearly getting to the apex is going to be very tough. We don't want to obviously.
Yeah, so that's actually a good question. Dr. Isha, actually, I was with her yesterday at the Encino. She had that same question, like, what's the best way to do like an open and med? For open and med, usually what I tell the doctors is to just do like a pulpotomy. I wouldn't even enter the canals. If you can just do a pulpotomy, just remove the pulp tissue in the pulp chamber. That's probably going to be good enough. If there's still a lot of bleeding coming out of the canals, then at that point you probably want to do more of a pulpectomy. But if not, then you can just do a pulpotomy and then just stuff the pulp chamber with IRM. The eugenol and the IRM is going to be sedative, so the patient should feel better. But usually, yeah, with a pulpotomy and IRM inside the tooth, that should be enough. Yeah, no cotton pellet, IRM directly inside the tooth. Yeah. And then, yeah, for this number 5, The working length was like 25.
I'm sorry to interrupt you, Dr. Kwan.
Yes.
What about eugenol on the cotton pellet and an IRM over?
That works too. Yeah, that works too.
Right.
I used to work at an office, old school doctor. He did exactly what you just asked. He did eugenol on cotton pellet and then just put Cabot on top of it. So that works too. That works too. But then you kind of just making two steps into one by just using IRM. So you can do that too. Okay. So here, I got this tooth number 5 on a Friday afternoon. The doctor, the associate that was there, he asked, "Hey, do you want to do this number 5?" And it was like Friday afternoon, like number 5, hell yeah, I'll do it. And we took a scan. I was like, ah, crap. So this is what I finished with, a mini molar. Again, if you see like some strange, it like just doesn't look right on the PA, then take additional radiographs and then you'll maybe get a little bit more information and see like, okay, maybe I should not do this tooth or on Friday afternoon. Here's another one, tooth number 5. There was a large cervical decay. It's a little bit hard to see on this x-ray, but this is what I finished with. You can see on the CT scan here on the axial view, the 3 canals there, mini molar. And then here's a tooth. I'm pretty sure this is tooth number 28. 3 canals on a mandibular premolar. This is like, I had to look it up. It was like 0.1% incidence. Extremely rare, but again, just take a lot more radiographs to make sure that you know what you're getting yourself into before you decide to do this case, do a case like this. So this case here, this is another tooth number 5. I was at the office that day with another doctor, and he decided that he wanted to do the endo on this tooth, which is totally fine. So he isolated, accessed the tooth, up-traded, took an x-ray, and then he came to me, showed it to me. I was like, man, it's the obturation was really short. It's probably short like 7 or 8 millimeters. So he went back, decided to he took out the obturation and then tried to do it, and then he came back to me and he asked me for help. So I was able to get the working length for him. I think buccal was like 26, lingual was 25, and then it was at the end of the day, so I packed up and left. So I thought, hey, I got him working length. He should be able to handle the rest. But already I know, just based on that case assessment difficulty form, the 25 millimeter long tooth is already going to be much more difficult to treat. I'm not even sure if the office had long enough files to handle a case like this. So I left, driving home. 15 minutes later, I get a call from the office, and the doctor talks to me and he tells me I broke a file. So I'm like, okay, just put the patient on my schedule and then I'll see what I can do. So I come to the office, we take a PA, and this is what I see. After a lot of trial and tribulation, luckily I was able to get the broken file out. So this is the instrument that I used to remove the broken file. And then this is my cone fit and my final. So again, if the tooth is like super long, you really should consider referring it out just because you're probably more likely to separate an instrument. Yeah, it just makes it so much harder. So consider referring a case like this out. I just want to play this little YouTube video.
Got a live one. Not root canal, and by the looks of those x-rays, it's not going to be pretty.
It's not even using that piece correctly.
Gator Gliddenville seems to be favoring that one lately. Well, I was doing the shoulder technique.
It's using a headstrong file.
That's not a headstrong file. That's a K-flex.
It's got a teardrop cross-section. Clearly a headstrong.
No. K-flex.
Headstrong.
K-flex.
There I go.
I'll go deflate him.
All right, go ahead and rinse. Oh, the human mouth is a disgusting place.
So true. But it's funny watching these representations of what we do. But anyways, so I just wanted to move into some of the referrals, some of the cases that have been referred to me. I see the notes from some of the doctors, and for me, I was like, I wish that the doctor would ask more questions and try to get more history. The things I would ask is like, when was the treatment done? Were they having pain? Was there an infection? Things like that. Just try to get more information from the patient. Because so much of that is relevant to how we're going to approach these cases. So this office, I went to this office, and this patient was on my schedule, tooth number 14. Already it just doesn't look right. It looks really strange. Like, why is there this giant, massive restoration in this tooth, clearly into the pulp space? So I thought, I saw the patient on the schedule, and I looked at these X-rays before I even saw the patient. I'm just like, maybe somebody tried to do like vital pulp therapy or something like that. But this is it. This was the only X-ray that was there. It was a new patient. Only bite wings were taken for this tooth. And so this patient was a 16-year-old male. He said, I noticed a bump on the gum that comes and goes. It has been happening for a long time. And this was news to mom. She had no idea. The patient just, I don't know, for whatever reason, just didn't tell mom about what was going on. So the patient came to me. So the doctor, the associate, she prepped the tooth for a crown, and then sent it to me for endo. And so this is what it came to me as. Um, and already from the bite wing, I mean, you can see there's something going on in the furcation. So that should already be a clue. I mean, you should take a PA anyways, like just like Shujal was saying earlier, like you should take PAs of these teeth that you can do crown preps on, because you need to make sure the the endo is okay on this tooth. Like make sure there's no lesion, make sure it's not necrotic. If it's a tooth with already an existing root canal, make sure there's no lesion, things like that. I mean, you really need to check for that before you decide to do a crown prep.
There's the clinical reason for a PA, and then there's the insurance reason
Right,
too.
exactly.
They'd
Right.
never accept any crown prep without a PA,
Yeah,
which makes sense.
of course, yeah. I completely agree. I mean, you need to make sure the perio is good, the endo is good, and that the tooth is restorable. So, please take these additional images. So the patient came on the day that I was there, and we took the PA, and this is what I saw. Here, the palatal root. I mean, there's something going on. This looks really funky. It doesn't look right, and it looks like there might be a lesion here as well. So we took the scan. So before I go to that, I talked to mom and I asked, like, hey, what exactly happened to this tooth? Like, who worked on this tooth? So she told me, of course, she doesn't like the details are fuzzy, but she remembers like the dentist who did it said there was a large cavity. We're going to do this filling on the tooth, and the tooth might need root canal. I mean, uh, the filling's in the pulp chamber. How can the tooth not need root canal already at that point? But he said he would watch it, and then he might need root canal in the future. And then she doesn't remember exactly when it was. So that's what she told me. Um, and he had a sinus tract on both buccal and lingual surfaces of this tooth. Not a good sign. Um, so this is a scan that we took. So here's this view here. I mean, you can see how wide the palatal canal is, and the lesion is massive. It's so big, it's going into tooth number 15. So I did all my testing. 14, of course, was necrotic. 15, by some miracle, even with the involvement of the lesion, was still vital. So he didn't need root canal on this tooth. So here again on the axial view, you can see the lingual plate is completely gone. Here on this view, the sagittal view, coronal view, the buccal plate is gone. So I mean that explains why he has multiple sinus tracts. And then here I centered the axial view directly on where this large part of the palatal canal is. I mean, look how thin these dentinal the palatal walls are on this root. So at this point, I mean, I told mom all the findings. I had to talk to the owner of the office. I talked to him and I said, this is what I see. The prognosis is really not good. Like, how do you want to proceed? I'm willing to try, but we need to have this discussion with mom and talk about like the financial, the long-term prognosis, things like that. And so we talked for a while, and then the owner doctor, he didn't want me to do the case because he knows if it fails, it's going to come back to him, and then he's going to, whatever he has to do in terms of like reimbursement. So, um, and then mom didn't want to take the chance that it fails and pay more money and blah, 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 whatever. So ultimately, we decided to just extract the tooth, and then the patient would do ortho to maintain the space. So again, that's why, you know, if you're going to prep these teeth for crowns, make sure you take a PA. You have a good idea of what's going on with the tooth, and the tooth is okay to prep. Because now, yeah, I mean, this opened up a can of worms here. Um, this patient was referred to me for tooth number 2, 4, and 31. 20-year-old female, and 31 was the one obviously that's going to need treatment first, but the caries on this tooth is just it's massive. I mean, you can already see here. You don't even need to take a probe. You already know it's invading biologic width, and so I told the patient, like, look, you know, we can do the root canal. I can do the root canal. That's not a problem. But it's the question of what's going to come after, because the caries is so deep. You should talk to the periodontist about crown lengthening, because we can't have success without endo, perio, and restorative. With a margin being this deep, trying to take a good get a good margin with your preparation, getting a good impression. I mean, the gingiva is going to be probably bleeding like crazy, and then for the lab to fabricate a crown for a margin this deep is probably going to be really tough. And then if you are able to do it and you deliver the crown and margins are sealed, they're still going to have most likely chronic inflammation, bleeding gums constantly. They'll probably have uncontrolled bone loss in the area as well. So have this discussion with the patient that, hey, you should talk to perio about crown lengthening. And 2 and 4 looked really big too. So I said, I told the patient, have them look at all 3 before you decide to try to save these teeth, because crown lengthening is not going to be cheap. You need to have all 3 of these before to save the tooth. So she saw perio. Dr. Mara said just 31 needed the crown lengthening. 2 and 4, I guess, were okay. So I did endo on all 3, and then I think she had the crown lengthening done on 31 as well. So again, just make sure, like, you know, just like with the restorative, we need to make sure the perio is good too. And she had no idea. The doctor that referred to me didn't say anything about perio.
How do you even like isolate in those cases when it's like subgingival? How do you even get the rubber dam around the mesial of that? Or do you just use it
I just
like,
clamp the gingiva.
yeah.
Yeah, I mean that's what we do. So I'll clean out the decay. I'll use some liquid dam
Oh,
to
okay.
isolate.
Yeah.
Yeah,
The
I'll use like the
mesial?
green.
Okay.
I'll use the green Lido to just jam it into the papilla to try to get hemostasis, and then quickly isolate with the liquid dam. But yeah, isolation on these kind of cases is tough for sure.
Thank you.
Yeah. This referral is from a general dentist. He the tooth fractured. He didn't remove the piece to assess restorability. We took a scan, and here you can see the tooth is fractured below it's subcrestal. So poor prognosis, I told the patient. Yeah, restorability, probably not that great. So the patient ultimately decided to extract the tooth. So if there's a tooth fracture like this, I mean, really, you need to assess restorability. Remove the fragmented piece if you can. Worst comes to worst, you have to do an open med if the patient's in pain. But please remove the fractured piece so that you can determine how deep that fracture goes. And then in this case, my initial reaction was, what the, what did they do to this tooth? Does anybody know what do you guys see in this tooth here?
Silver points.
That's a good guess. That's a good guess. Anyone else? But so yeah, this patient, the office, they asked if they can refer this patient to me, and I'm just like, what the, what did they do to this tooth? So it almost looks like there's a broken file in each canal. But actually, what it is so an endodontist developed this product called it's like an obturation-based carrier, gutter purchase. And so the initial design was a metal core, like a metal post basically with gutter purchase surrounding it. And then you just put it into all 4 of the canals once you're done instrumenting. I mean, all of them are out the apex. And I mean, there's a lesion on both roots. Actually, there's 3 roots. I can't remember there was all 3, but this mesial for sure. And so initially my reaction was to just tell the patient to extract the tooth, but then I was like, I want to try. But I told them, I'll do this case, but the patient needs to understand that they need to pay for extraction for like each canal, because this might be really tough to remove all four of these carriers. And then if I'm not able to remove them all, the patient still has to pay for something because I'm not going to do all this work for nothing. So the patient needs to know that going in. So they let the patient know, and the patient ultimately decided to just extract the tooth. So yeah, this is just one of the cases that were sent to me. So the newer version of this would be like they call it like gutta core. So instead of like a metal carrier, it's like a gutta percha based carrier. Still a pain in the butt to remove. So and the success rate of these obturation based carriers are really low, something like 30%. So now I just talk about some of the cases that I actually did do for some of the referrals that were sent to me. So this case here, 44-year-old male, RCT number 19, completed in India a few years ago. So it's previously treated and symptomatic apical parodontitis. He was saying he was having pain on biting. Um, so here, this root canal, you can see it's under-instrumented, underextended, underfilled, massive lesions on both mesial and distal roots. But the big thing for me was that here's the IA, and you can see the lesion is into the IA. Surprisingly, the patient didn't have any paresthesia or dysesthesia. He said he felt completely normal. So we took a scan. So here again, you can see the lesions into the IA. Here's another view. So yeah, I mean, you can see it's invading the IA. So maybe somebody can answer this question because I'm not really sure. If OS were to extract this tooth and we can see there's a clear involvement with the IA, or if somebody were to extract this tooth, they want to do bone graft. And, I mean, how would you repair this IA canal? Maybe somebody has an answer.
From what I know, with this large of lesions, you're supposed to kind of just like let it heal on its own. And then afterwards, if you need to like graft vertical or horizontal, you do it. But initially, like you don't even like try to scoop it out or anything.
Right. Okay.
Yeah.
Okay.
You're supposed to let the body like heal it. Because like scooping it out might just cause more damage.
Okay.
Yeah.
Okay. Would anybody be willing to tackle this extraction?
I can do it.
Okay.
Yeah.
I'll do it.
Yeah, we
Yeah.
do it.
Okay.
Send it to Gilbert.
Yeah. So, I talked to the patient, I gave him the prognosis, told him, hey, this infection's into the IA. Um, I would recommend trying to do the root canal. Maybe we'll get some healing because the IA is exposed. And again, I'm not really sure what the healing success is going to be, but let's give it a try. Patient agreed. So this was, here's the initial. Here's my final. So for this, the obturation, usually if the tooth is necrotic or previously treated, I mean, there's no tissue in the canal. So that sealer will just flow right out the apex if you push really hard. So for this case, I was super careful when I obturated the canal. You can see just a little bit of sealer here, maybe at the apical foramen here, but I was very careful because I knew there was communication with the IA. So I obturated very slowly. And then, so this is my final. I had the patient come back in 3 months, and this is, there's a lot of healing. Yeah. So the lesion on the distal root looks like it's almost completely gone. The mesial is decreased substantially in size, and the patient was asymptomatic. I did have to do multiple rounds of calcium hydroxide because he still had pain on biting. So I think I did it like 3 times. But he was asymptomatic when I finished, and then 3 months later, he's okay. So perio on this tooth is good. Whoever did the restoration did a great job. And then the endo looks okay too. So success. This one, 62-year-old female, tooth number 19, pulp necrosis, chronic apical lapses. She said she had pain on the tooth for a while. The doctors couldn't figure out what was going on. So we took x-rays, scan, all that stuff. And then this is what I saw. Tooth number 19. So, I mean, there's already furcation involvement. The lesion is massive. I mean, you can see it exiting out here. So it's perio-endo at this point too. So I had a discussion with the patient, guarded prognosis, blah, blah, blah. Are you sure you want to do this treatment? She insisted on trying to save the tooth because it was the last molar in her mouth on the lower left. So she really wanted to try to save the tooth. So I initiated treatment, calcium hydroxide, and then this was the final, and then 3-month recall. So you can see the It's actually starting to heal, the bone's filling in. Hopefully I can do long-term follow-ups, but initially it seemed to be okay. The sinus tract that she had resolved as well. And then she was insistent on not getting the crown placed because she didn't want to pay for the crown if it didn't work. So she was in a temporary for like 3 months, or it was longer than that because I did calcium hydroxide too. So that's fine. I mean, I did the orifice barrier, so it should be protected. The temporary stayed on the whole time as well. But yeah, I mean, it appears to be working. Can anybody guess how old this patient is? Tooth number 29. So I mean, there's an open apex on this tooth. She was 42. She said she had a bump on the gum. She doesn't remember having trauma on the tooth. There's maybe some like an incipient lesion here, super small, but there was no sign of cracks or fractures, nothing. But the apex was wide open with a huge lesion here. So in cases like this, when the apex is open like that, we can't really do standard obturation techniques with gutta percha. It just won't seal. I mean, here on the CT scan, the apex is so large, you can probably drive a bus through that. I mean, that thing is huge, you know. So we need to think of alternative treatments for something like this. So again, for a case like this, I did calcium. I might have done like 1 round of calcium hydroxide. By the second visit, the sinus tract had resolved. And then here I did an apical plug. So I use a bioceramic material to place at the apex. And then I filled the top with gutta percha. And then here's the 6-month recall. So again, you can see the bone is starting to fill in. She said the tooth was asymptomatic, the sinus tract hadn't returned. So told her like, yeah, you should be good. I mean, you should be okay. The treatment seems to be successful. So open apex cases, yeah, we need to think of alternative methods of sealing the apex. This is the last one, 28-year-old male number 3, retreat, guarded prognosis. This was the initial x-ray. Large lesions on the palatal, the mesial buccal had a big one. I mean, it was not nearly as big as the palatal root, but it was pretty large. So I again had the discussion with the patient, guarded prognosis, and then he's like, I don't want to lose a tooth. I'm too young, so I want to try to save it. So I did the retreat. So that's my final, and then this was a 6-month recall. It's a little hard to tell from the PA if the lesion is getting smaller or not. So we took a scan. So here's the initial. I try to line up the planes exactly the same. But I mean, the palatal, the lesion seems to be getting smaller. So I told him, yeah, it looks good. I mean, you might be okay. So we just continue monitoring. That's all we can do. And that's it. Questions?
Cool cases.
Thank you.
Very,
Yeah, you're a
very.
beast.
Dr. Kwan, I have a patient. Sorry, I have a question. Do
Okay,
we
sure.
prep and temp before we send you for endo?
Say that again.
You want us to prep and temp for a crown before we send it, or does it matter?
Ideally, I would say yes, just because I want to make sure I'm doing endo on a tooth that's restorable. So this was a point that I brought up before. What I consider restorable, you might not consider restorable, and what you consider, vice versa. So by prepping the tooth beforehand, at least do your rough prep, make sure the margins are clean, and then you'll know for sure that the tooth is restorable. If you're afraid of touching the pulp, then just leave the caries at the pulp, and I'll clean out the rest. But for me, that's key. Like I've had to tell patients patients that refer to me, where for me, even for me, I look at the tooth and I'm like, man, the restorability is really questionable. So by doing that, then you know that you can restore the tooth. I had there was one office I went to where I think I asked this question before to the chat here, and I said like, hey, how many walls do you guys need to consider a tooth restorable, right? And so Dr. Anish, what would you want? How many walls do you want?
Probably good with 1.5.
1.5, okay. Dr.
1.5.
Gilbert?
I'd say, yeah, probably 1.5, 2.
Most of the doctors I talked to have said 3. They feel comfortable with 3. 2 is maybe. The office that I went to, the associate that referred the case to me, there was one wall left on the tooth. I was like, you're asking for you're asking for a miracle here, you know? To get down on your knees, start praying because I don't think this tooth is restorable. Um, for those offices, it's like there's an owner and an associate. Um, Associates, they come and go, and then the owner is left fixing the mistakes once the associate's gone. And so, I don't want to put that on the owner. I don't want to put that on the associate. So please, just make sure the tooth is restorable before you decide to send it over. And a great way to tell if it's restorable is by prepping the tooth beforehand.
And it makes the final impression a lot easier.
Thank you.
Yeah. Anything else? Dr. Isha, you had a lot of questions yesterday. I don't know if you have any more.
No, you answered. Oh,
Okay.
yeah.
Okay. Okay. Then I guess that's it. Thank you.
Thank you, Dr. Kwan.
Thanks, Doc. I just want to highlight how lucky we are to have doctors like Dr. Pizza, Dr. Kwan. We have a lot of great specialists in our group. So, and we're lucky in Dr. Kwan's case that he worked as a general before, because most endos, if they get a case, it's coming back with the endo done. And Dr. Kwan will do what's right for the patient. If he doesn't think it's restorable, he will send it home. So, or send it back to you guys. You are home. So, we're lucky to have people in our group who are not money hungry and they do what's right for the patient.
Great. Thank you, Dr. Puri. So some of the operations updates that we have right now is calling your own patients for the doctors. I'm sure you've seen the sheets going around in the offices. So, the main point is case acceptance. We would like all the docs to call your patients back if there is a big treatment plan that, didn't got accepted. Call your patients and see where the patient's mind is at. Maybe we can help them out with, doing small treatments at a time, not the big treatment, not everything together. So call your patients back. If you did extractions, it's good to follow up with the patients to see how they're feeling. Also for crown preps, deliveries, to see if, the crowns are okay. So call your patients back when you have a downtime between patients. Referrals, we have some great specialists, as Dr. Puri mentioned. Let's direct all our patients to our specialist if they need any kinds of treatment. I'm sure they'll take care of our patients really well. Blood pressure, Dr. Puri, you want to?
Yeah, I can go over it. Couple things with calling your patients. I always call my patients a week after, because whenever I present a treatment, I expect it to be accepted. That's just how I operate. So if a patient has not accepted or is not on my books, I feel like they should be on my books. So I check the charts from the previous week. I give them 1 week to kind of think about it. And then I call them and I say, hey, Dr. Gilbert, just checking in. There's some things that we discussed last week that you need taken care of. And I was, checking in. The patient doesn't feel pressured to do the treatment, but they do feel like they're being taken care of. Very high acceptance rate. They're like, okay, you're right. I'm going to schedule it. Can you connect me to the front? And then that's it. Literally a minute call. Or if they can't do it for any reason, they're traveling or whatnot, they still feel taken care of. So it's a huge patient builder too. So I think it's something good. I'm going to have the office manager start, printing out a little list for the doctors to call. It's going to take maybe 5 minutes of your day. So I think it's a good idea for us. Another thing, blood pressure. we need to start taking more blood pressures. So anytime we inject a patient with anesthesia, we need to take their blood pressure, whether they say they're healthy or they were healthy and now they're taking medications. If it's a crown prep, it doesn't matter. Anytime or even SRPs, if we are injecting the patient, we should, or if we expect blood, take the blood pressure. The reason I'm kind of harping on it right now, last Tuesday, I had a patient, blood pressure 226 over 126. Sent her to the ER. 3 days later, had a quadruple bypass, open heart surgery with 99% blockage.
Wow.
We saved her life, you know. I'm not even worried about her dental work. I'm worried about her as a, as a human. She's got a family and she's got people who care for her, so we saved her life. I had a patient yesterday, same thing. 2 weeks in a row, 226 over 120. So, I sent him to the ER as well. So don't be scared to send people to the ER. A lot of people have health concerns, and a lot of people don't go to their primary care physician, so they have no idea. People see us as dentists more often than they see their MD or DO, whatever they see. So I created some guidelines for us. It's just what the ADA is recommended of when to do treatment, when to do emergency treatment, and when not to do treatment, and when to refer to the ER. But we're going to start pushing that blood pressure on every patient, and we need to put that in our notes. In open dental, they have a vitals area, but I like to have it in the notes as well, just so that other doctors, if they ever see that patient, can see kind of the baseline. So, I mean, we're doing great stuff. So, we can take care of patients' systemic health as well. Okay, so next point, other than blood pressure, is medications after extractions, after root canals. Almost everyone here has a dose spot login. And if you don't, please reach out to me or reach out to Shrujal.
Oh, actually, on that topic of medication, let me add a point. If you guys are gonna refer a case to me with a patient with like an abscess, sinus tract, fistula, whatever's, I actually prefer not to have the patients on antibiotics. If they have facials, usually I tell patients like you really don't need antibiotics for root canal therapy. The only time I recommend antibiotics is for if they have like if they're feeling feverish, if they're the cellulitis, like their face is swollen, lymphadenopathy, malaise. Those are the only times I really prescribe antibiotics. For sinus tract, periapical abscess, it really doesn't do much. It actually makes it more difficult for me because uh, in those kind of cases where there's a sinus tract, probably I'm going to medicate with calcium hydroxide. And then for me, like when I bring them back, if I see that the sinus tract has resolved or gotten smaller, then I know the treatment is working. But if the patient's already on antibiotics, the sinus tract most likely will be healed. And I'm not sure if the treatment is if it's because the treatment is working or it's from the antibiotic or it's probably going to be the antibiotics. So as long as they're not like the feverish or swollen, then that they really don't need antibiotics.
Sure. And that's for endo, but for extractions, we especially because we're doing bone graft, we want to ensure that that bone graft takes and that the healing is good and predictable. So please make sure you do your dose spot by yourself. What I've been hearing and seeing is that we're telling our front staff to call in the medication. I don't know if any of you guys have ever called CVS to try to call in medication. It takes like 35 minutes. It is the most inefficient use of their time. That's one. And number two, a lot of times they mess up the prescription in terms of the pharmacist. CVS does, and they don't put it in. And then guess what? You're home, our team is home, and the patient doesn't have medication. And that includes pain medication as well. So that happened about 12 times last week. So that's a big pain point for me right now. So call in your medications. It's your responsibility as the doctor. And that kind of goes on to kind of the next point. I think we're doing great work. We're doing awesome. I do want to put a little more responsibility on our doctors. And that goes from front, when the patient walks in to when the patient leaves. So we need to monitor our wait times as the doctor. You need to make sure your patients are not waiting in the front. If you're sitting and writing your notes and your assistants have not called in the patient and taken the pre-op x-rays or done anything, you should be directing that flow. I've noticed that happening where, the doctors are writing your notes, fine, you can write them, but direct the flow, get the patient in. Patient's appointment's at 2 o'clock and the chair's been open since 1:58. Why are we seating him at 2:15? It doesn't make sense. So we should get them in, get the process going. They can take the prelim impression. You can numb them, then write your notes, whatever it is. Just get the ball rolling, manage the flow. For new patients and exams, please check what your OM is presenting. Is it the right treatment? If you said, and you had a discussion with the patient, that I'm doing number 2 crown, why is your office manager presenting 2 and number 30? Right? So we want to present everything to the patient, but at the same time, we need to make sure that things get accepted. So if the patient says, I only have money to do number 2, that information needs to go to the OM. So instead of seeing $1,000 copay, they're seeing a 500, they're much more likely to accept. So first step, getting them in on time, making sure the treatment plan is correct. You guys have access to see what it is, making sure consents are taken, which, as Shrujal mentioned, we're doing a good job on it. And then through the end, every office should be giving their patient warm towels. We spray it with lavender, makes it feel like a spa. The patient remembers that. First impression, getting in on time, and last impression of, having the warm towel. Feels good. Okay, I did a good job. I'm done. Rather than first impression being late, then getting stuck by a needle, and then having junk, temp cement all over my face. It's just easy ways to make the patient experience a lot better. And at the end of the day, your assistant is doing most of it, but I'd really appreciate if you guys took a little more lead on that. The doctors who do it produce way more. I can tell you guys right now. So that is another additional point I wanted to bring up. Any thoughts?
Yeah. Yeah, and when it comes to the new patients at the front, we're also doing new patient tours. So, we're starting off with the best impression, and everybody does their job, and at the end we'll ask for good Google reviews to close it up.
Yeah, just from my perspective, a couple of things. So yeah, Google reviews, slow and steady, always wins the race. The offices with more reviews, and it comes from the same doctors, they're the ones that get more patients, and production grows over time. And it's just asking nicely, asking the front desk to give a floss for review, or even just being nice and even asking for it. Doctors can even ask for it if you guys do a big procedure or you have a good rapport with the patient. Those things go a long way. The other thing is warm towels. Almost no dental office does warm towels. Pre-dentistry, we started that 30 years ago. Many of our offices do it, but not consistently. So it's a huge differentiator for new and existing patients. So that's something I would keep an eye on. The last thing we consistently see patients mention in reviews is cleanliness of the office. So if you see that your office or an operator you're in is not clean and you have assistants waiting around, it's a little bit of a slow day, or even if you're overstaffed on assistants, we try to give you plentiful assistance always. Ask them, hey, could we clean this? Or can we make sure this is clean? It is probably the number one thing I see in reviews, besides friendliness of the front desk, warm towels, and cleanliness. So remember, patients don't always know what's happening in their mouth once the pain is subsided. But these 3 or 4 things are what they remember. And the friendliness of the doctor, our bedside manner. as well.
Yep. The reviews always mention no judgment from the doctor and cleanliness of office and the spa-like feeling of the warm towels is simple. They don't care how impacted that number 32 was. They know the tooth's out, you know? So
Yeah.
definitely.
Okay. Pearl AI, we have Pearl AI that, it's a really good, nice tool to see the sections of the teeth and highlights the problem areas. So make sure it is on at all the times.
Really, really quickly on Pearl AI, do you guys know how to use the tooth parts on it? Give me a sec. I'm just going to show this real quick and then let's move to, because we can do Danny and then I think we'll be good.
Yeah.
Sorry, give me 1 second, guys. I'll share my screen. This patient has all implants.
Go to my patient today at Beverly Hills.
Yeah, give me a sec. Do you remember what his name was?
Robert Lyle. 2 o'clock.
Yeah. Okay. Can you guys see my screen?
Yep.
So with this Pearl AI, if you use those tooth parts, it's a lot easier for the patient to see, for example, how close the decay is to the nerve and why you're doing a filling versus, watching it with the incipient. Something as small as this. You can also use these spotlights, to show. So make sure you guys are using all this. The invert doesn't really do much, but helps with looking at parls and whatnot. Definitely use that. Okay, sounds good. Danny, are you with us?
I am. Sweet. I can give a quick introduction. I think I've met some of the folks here, but for folks that I haven't met, I'm Danny. I'm the CEO and founder of Avora. By the way, Dr. Kwan, I enjoyed your presentation. I was following along until Teeth SOS, and then you lost me a little bit, but always fun to learn. So as I was saying, I'm the founder of Avora. Avora is a new AI platform primarily designed to do 2 things. The first is save you time on notes. So take notes for you automatically via ambient dictation. And the second is to help you improve case presentations. I know it's late and I don't want to take up too much of your time. So what I'm going to do really quickly is just give you guys a sneak peek of what Avora looks like. I'm actually going to be in practice next week with hopefully everyone that I haven't met so far, setting up the rest of the practices that I haven't yet. So right now, Avora is already functional in Camarillo, Puri, and we just set up Hillview the other day. And so I'll be doing the other 6 practices all of next week. And really the goal will be to do some in-person trainings with you guys, to work out any kinks, and to really make sure that everyone feels comfortable with the platform. Before I jump into it, I'm just curious, how many of you have heard or seen AI note takers, minus Avora for the folks that have already tried it? Cool. That's right. Sweet. Well, I'm excited to show you guys what it looks like. What I'm going to do is share my screen, and I'm going to walk through a quick demo where we filmed a fake patient exam back when I was at Dr. Puri a week and a half ago. And what I'll show you guys is how Avora uses that to write a note, and how it will also give some feedback and tips on case presentation. The last thing actually to mention before I jump into it is you might be wondering how are we actually recording the appointments. So all of our offices are set up with these little conference microphones. They just sit on a counter, and you sort of forget about them after it's been plugged in. And you are responsible for starting and stopping recordings. Usually it's going to be your assistant or the hygienist who starts and stops it for you. But my point there is that you're in control of when you're actually doing recording. So it's not always on. Awesome. Can we see my screen? Perfect. So I know we're looking at a lot here. Really high level, what I'll bring our attention to on the left side here is a transcript of an appointment. And again, this was me playing out a fake exam with Dr. Puri Sr. And we're not going to read all of this, but I'll just point out that, Dr. Puri asked me why I was there. And I said, oh, I was playing football and I got hit in the face. Dr. Puri said, okay, we're going to do some x-rays. Talking about if there's no root fracture, we can save the tooth. Talking about the possibility of a root canal and explaining to me what a root canal is. And finally, Dr. Puri is mentioning the tooth number. And I'm also throwing out there that I'm allergic to penicillin. So a lot of information, we're having a lot of background conversation. What Avora is going to do is take all this information and put it really concisely into a note that looks like this. So these are already all of the note templates that you're used to. So we just pulled the notes from Open Dental, and then Avora goes in and fills in the information that's going to be relevant for that note. So here we were talking about, I got hit in the face by football. We were talking about all of the damage and findings on number 8. And that possible root canal that Dr. Puri is mentioning. So again, what's happening here is we are recording an appointment and your exam with a mic that looks like this. All of this is happening ambiently, so all you're doing is just talking. Once the appointment is done, Avora processes that information, puts it into a nice compact note for you, and actually exports it back into Open Dental. So when you're reviewing your notes at the end of the day or during lunch, the note is just in the chart there, ready for you to review. What questions do folks have so far that maybe haven't used Avora or this is a new concept?
So I just want to say, like Dr. Kwan was saying, he wishes that we asked more questions. This is such a great tool that it's going to record everything and write in our notes exactly what we talked about. And even Dr. Kwan can go back and listen to the conversation if he wanted to in this Avora. It's an amazing tool. And I think if we all buy into it, it could really help everybody. And if you want to learn how other doctors present treatment, you can go back and listen to the recordings, things like that. That's all I got.
Yeah, I used it Tuesday for the first time. I don't know if any of you guys have seen my patients, but I don't really write great notes. That's just that is something. But I'm looking back on my notes from Tuesday and they're fantastic. They're better notes than I ever would have written. So as I'm doing my exam, I'm looking at a patient right now. Okay, chief complaint is written here. Number 3, previously treated tooth with periapical infection, endodontic retreatment indicated and recommended. Number 4 has a existing root canal, no treatment needed. Number 5 has a porcelain chip. It's asymptomatic. We will monitor for now. And then it just goes tooth by tooth with existing. So when in this example that Danny gave us, it's only talking about one tooth. Like we can type this, I get it, but when you're doing a comp exam, there's 28, sometimes 32 teeth there. So all of that is written and you're already looking at it. So it's very, very comprehensive.
You can also press record. The microphone will be in each doctor's room. You know, I like to go over it in the doctor's room and just look at every tooth, kind of start treatment planning. You can also start recording. You can press record and you can just call out, I see number 8, you know, existing RCT, doesn't have a crown, whatever you want to say. Any, you know, number 3 has an old amalgam, enamel fracturing, recommend crown. Like that's how I talk to the microphone in the doctor's room. And then you can also press record when you go in the room, find out, you know, any history, or you're talking to the patient about, you know, their job. It'll write all this down. It's a great tool.
And then I want to call out 2 more areas where Avora is going to make your life easier. The first is a feature we have called handoffs. I'm just going to reload my screen here really quickly. Oops. My internet just went out there. Give me 1 sec. So what I was saying is that 2 more areas where Avora is going to make your life easier is in your handoffs. Can you guys still see my screen, or?
No, you have to reshare it.
I see.
Yeah. Yeah, we're good.
Great. So while an appointment is happening, before you've gone into the room, you know, your assistant might be having a conversation with the patient. And normally you would ask them what information, you know, what the patient's chief complaint is, what their medical history is, etc. What Avora allows you to do is, while an appointment is running, actually go and see a handoff that's going to tell you everything about that patient's chief complaint, any concerns or questions they have, medical history that's relevant, and basically give you a cheat sheet before you walk into a room. The last thing that I'll mention is we were chatting about Avora helping improve case presentation. What Avora will do is go through and give feedback on how a case presentation was actually done. This was obviously a really short demo that we were filming, so you can see that Avora was calling out, hey, we didn't ask the patient to take a look at an x-ray or, you know, look over findings with us, but basically give you feedback step by step on areas where there might have been an opportunity to build some better rapport with the patient, explain something better, and really just nail, you know, that chairside presentation. And so where a lot of our providers find this really useful is for a difficult patient or a difficult case, just making sure that you're hitting all of the steps that you want to hit. And so on the theme of case acceptance, you know, when a patient says no, you know that the reason they said no wasn't because of something you could have done chairside. And that's pretty much it. So to summarize, you know, really the point of Avora is to save you time on notes, to help you out with case presentation, and to just, you know, streamline information flow in the office so you can really just focus more on patient care and not on administrative work. Really excited to spend some time with you guys in person next week.
Amazing.
Thanks,
Thank
man.
you.
All right. Thank you for all the great presentation, Dr. Kwan, Danny. Avora is amazing. We're using it at Perio Dentistry. We love it. Yeah, let's end it right here. Thanks all for joining. We'll meet again next month. It's going to be the last Wednesday of the month.
Yeah, thank you, everyone. Last point
Thank
I'd
you.
like to make, if you guys have any good staff you'd recommend to us, front office, dentists, or assistants, even hygienists, please send them over to us. You know, we've now interviewed I think I've personally interviewed about 700 dentists, and I've chosen this group to join our team. So, and we've done the same with front and assistants, and we're constantly looking for the best team, and obviously always training everyone. So that's the most important thing that I'm working on. So if you do have good referrals that you have, it can really uplift an office. Please send them over to us. Okay. Thank you, everyone.
Thank you all.
Thank you.
Have a good evening.